Like you're, I don't know, it looks too home video when you put it
Yeah.
like that, you know, if they're looking straight into the camera.
Okay.
So anyway, so how long have you worked in oncology?
I have been in oncology for 6 years. 6 years. All over the place.
Did you go straight into oncology?
Yeah, I finished school in 2001 and went right into oncology about a month later. So.
And why oncology?
When I was in college, my sophomore year, I volunteered at a camp up in Pennsylvania called Camp Raising Spirits. It's a weekend camp with cancer patients and survivors. And it was just this nice thing in a Mennonite camp. And it was 2 days, and it was just all these activities for all these survivors or people who had cancer. And I just thought, this is a great population of people. I could probably do some good here, and that's why I went in there. I just thought, okay. And it's paid off. That's what, I thought I would. I met the kind of people I thought I would meet, so that's why I picked oncology.
And you've only ever worked in oncology?
I did a very small stint as a labor and delivery nurse for about 2 months, and it just wasn't my cup of tea. So.
So you've been working in it 6 years. Have you seen, have there been a lot of changes in cancer treatment since you've been working?
Yeah, there have. They've come out recently with a lot of the monoclonal antibodies like Avastin, Erbitux, and the way that they work versus traditional chemotherapy. It's just a different option for patients that may not be able to tolerate traditional chemotherapy. And also with anti-nausea medications, they've come a very long way, even in the 6 years. And I know even in the past 10 years, they've come a long way with what they can offer people now for antiemetics. So I've seen a lot of advances. There's a lot of new different surgeries also with breast cancer. Just a lot of options, and it's constantly happening. They're constantly making new drugs. So.
Have you worked on the surgical side of things?
I've dabbled in a little bit, but never fully been part of a surgical oncology floor. But I've dealt with a lot of it with just the chemotherapy part of it. You also get a taste of the surgical part of it too.
Do you get? What's loud? Do you get to know your patients fairly well, or is it more like they're just sort of in and out?
No, you get to know them pretty well. They become like your family. You become like their family. When they have a bad day, you have a bad day. So you do. It's a big attachment to the patients.
And when you're dealing with patients who've just been diagnosed, what kind of information do you try to provide them with?
I try to, first of all, provide them with the fact that just because they have cancer doesn't mean they're going to die, because that's the perception that a lot of people have, is that I have cancer, I'm going to die. I also try to let them know that just because you have cancer, you're not going to be walking around throwing up. You're not going to have to be far away from your family. That if the treatment doesn't fit you, there's something else out there that we can try. Just try to give them a lot of hope, because just because you have cancer doesn't mean you're going to die. So that's what I try to instill in them.
And what information are they usually looking for?
They are usually looking for, how long do I have? Am I going to lose my hair? Am I going to be throwing up all over the place? Am I going to be able to kiss my spouse, kids, grandkids? And am I going to be radioactive? Those are the main questions I get asked all the time. So.
Have you ever done any kind of, I guess patient education is part of your work, but have you ever done any work that centers around patient education?
It didn't center around patient education, but where I'd worked previously, we were the pharmacist, the nurse, we were pretty much everything. So the patient education part came to us. So we would educate patients pretty much 4 or 5 a day on their medications and resources and what to expect, what not to expect, that kind of stuff. So never primary education, but a lot of it was a big component of the job.
What are the cancers you see most often?
Colon, breast, lung, non-Hodgkin's lymphoma, and I saw a lot of head and neck cancers.
I'm just repositioning the camera. It's kind of like going up a little bit. I don't like the angle. But still, don't look at the camera. You can look
Okay,
at me.
not looking in the camera.
Hold on. That's a slightly different angle. See, now I'm using my hand as a tripod, which I'm not really that good at doing. But all my questions are almost over. What do I wanted to ask you, what is, you mentioned monoclonal antibodies and the targeted therapies being different from traditional chemotherapy. How, I know there's a real technical answer to that because I've been doing my own independent research for a couple of years now, but if you were describing this to a new patient, how would you explain the difference?
I would explain that, take for instance Avastin versus just your regular old 5-FU, which you use for colon cancer. 5-FU is a systemic. It kills the cancer cells, but it also can affect the healthy cells, whereas Avastin is more targeted towards the cancer cells, the tumor site. And what Avastin does is basically cuts the blood supply to the tumor or the cells so that it doesn't have basically the food it needs anymore to continue to grow. So it's the basic, best layman's terms that you can put is that with the regular traditional chemotherapy, you're getting all the cells, not just the cancer cells, but with the targeted therapies or the monoclonal antibodies, they're more specific to a tumor or a certain type of cell. That's all.
What about Erbitux?
That's a little bit trickier. I don't know if I can put that into words how I actually explain it, but again, it's not doesn't do the exact same thing as Avastin where it targets something, but it's more specific to a type of cell, a marker on a cell that is expressed in a lot of colon cancers. So it's a targeted therapy, but it's not exactly the same. So kind of.
Well, it's an Erbitux that alters the DNA of cancer cells so they cannot reproduce.
I know Erbitux has to do with the EGFR expression.
It's a VEGF inhibitor.
But if you would ask me the specifics about Erbitux, I just know mostly the side effects. So my explanation kind of gets hazy at that point because I'm more in the side effect portion of the thing than the actual breakdown of what it does.
Over the past few years, has the new generation of drugs helped patients a lot with side effects?
Yeah, some of them don't. They don't have the same side effects. I know Avastin can cause nausea, but it's not the traditional set of side effects. It's more sometimes bearable side effects like rashes or things that people may not even notice, like high blood pressure or protein in their urine that they may not even be aware of. But unfortunately, I think sometimes with those medications, when you're getting them, there are more risks when you receive them for reactions to the medication when you get them versus down the road. Whereas with most traditional chemotherapies, there's only a few that you usually can see an allergic reaction to or some type of hypersensitivity reaction.
Do you plan to stay in oncology?
For the time being, yeah. I don't know where I see myself in 5 years, but yeah, for now, this is where I like to be. This is what I feel comfortable doing, so I plan to stay in. And there's still a lot of work to be done in oncology.
And what's your last name?
Visnick.
Oh, I knew that. Visnick.
Yes.
Okay.
All right.
Thank you.